Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today we will discuss about a case of scleromalacia. We will talk about its presentation, signs and symptoms, and the management. We talk about this interesting case of scleromalacia. This is a female patient, 60 years old, and her vision is right eye is no perception of light, and the left is hand movement. And if we see in these photographs, she has got scleral thinning 360 degrees, and in the left eye, which is the good eye, she has some vision, counting fingers. The activity is there in anterior chamber, plus 4 cells. The lens, the IOL, which was scleral fixation, has dislocated into the anterior chamber. So in these first photographs, we can see there is thinning all around 360 degrees. Other photographs showing inferior section and nasal side, here we can see how much extensive thinning of the sclera has happened, that we can see the bluish tinge, discoloration, and this is involving 360 degrees. So these are inferior and nasal sides. The temporal side, again same condition, thinning is extensive, but yet it has not reached that stage where we called scleromalacia perforans. No, it is not yet that stage. It is just diffuse thinning and anterior chamber activity with plus 4 cells, dislocated IOL, anterior segment. Some other slides, again, blood vessels are congested, ciliary congestion all around, and scleral thinning. Look at this photograph. You can see here that the IOL which was implanted, which was in fact, as per the history and we have seen, it was scleral fixation IOL, it has dislocated into anterior chamber. Especially in the one photograph, the margins of the IOL are beautifully shown by the photographer. We can see that the lens is now in anterior chamber. This is retroillumination. These two slides showing the location of the IOL and scleral thinning, scleromalacia, again in these photographs. The fundus photograph and fundus fluorescein angiography. Here we can see occasional areas of leakage over there with obliterated blood vessels. This is the endothelial cell count. Of course, in the left eye, when the IOL is displaced in anterior chamber, both eyes in fact, it is affected, but severely decreased endothelial cell count in the left eye. The patient has also got right pale disc atrophic changes over there, and RNFL we can see over there that how the retinal nerve fiber layers are also affected. Let's have a look at the MRI of the patient. Right side, the optic nerve has got undergone some atrophic changes. And if we talk generally about the report of MRI, there are microangiopathic changes in the brain. So these are the few photographs of the patient which I have shown you. So as this patient presented to us in our emergency, we started the treatment. On the left eye has vision, counting fingers 2 feet, and anterior chamber activity was plus 4 cells. IOL, which was scleral fixation, dislocated into anterior chamber. So we started our blood workup, and we came to know that this patient is VDRL positive for syphilis, quantiferon also positive for tuberculosis, RA factor positive, and anti-nuclear antibodies 1:640. So we started this patient and we contacted and consulted infectious disease department, rheumatology department, and even the glaucoma team was consulted for high intraocular pressure. It's but natural, so much inflammation was there. So in consultation with all these teams, Even neuro-ophthalmology was consulted. We started this patient on pulse dose methylprednisolone 1 gram daily for 3 to 4 days, and after that 1 milligram per kg we started oral prednisolone, which will be gradually tapered off. Simultaneously, we also started mycophenolate mofetil 1 gram BD 12 hourly, which will be gradually tapered off to 500 milligram BD. The reason to start both of these is simultaneously is that mycophenolate mofetil usually takes some time to affect, 3 months at least. So meanwhile, this methylprednisolone and oral prednisolone tablets, this will control the inflammation. Topical prednisolone acetate eye drops, beta blockers to control pressure were also given. Now coming to the other point, the patient was positive for syphilis. So the infectious disease department consulted, and we also started penicillin treatment, injectable, for the management of the syphilis. As I mentioned earlier, the patient has quantiferon positive for tuberculosis, so we also put him on rifampicin and isoniazid for the coverage of anti-tuberculosis. So this is the situation of the patient. We are managing. The inflammation has settled down in anterior chamber, and we will continue this therapy. This was a very interesting patient, so I decided to discuss with my respected audience. And once the inflammation settles down and disease comes under control, this dislocated IUL can be removed. But as you have seen in endothelial cell count, that severely decreased, especially in the left eye. So visual prognosis will not be that much good. But first of all, we have to control the inflammation, because still it has not gone to the stage where we called it Scleromalacia perforans. No, it is not gone that much. Scleromalacia, basically an autoimmune disease that may happen because of rheumatoid arthritis in elderly female patients, then SLE, systemic lupus erythematosus, polyarthritis nodosa, Wegener's granulomatosis. So these autoimmune diseases can cause this type of disease, challenging. But as I always mention, the timely intervention is very important. Still, we can restore and save even if she has got navigational vision. And if the patient is not managed properly at this stage, it can go to the Scleromalacia perforans and eyeball can be lost. So this was a very interesting patient which I decided to discuss with my respected audience. I hope this challenging patient and challenging case will be beneficial in your clinical management.